Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Sheila. I have the results of the electrocardiogram and chest x-ray that your GP sent you here to get. But first, I just want to review your symptoms to get a complete picture.
OK, sounds fine.
So you're a student, is that right?
Yes, in my last year of university.
And so when did the shortness of breath start?
About 10 days ago, I think. At first it was after I rushed from one class to another or had to go upstairs. I figured it was because I had not been exercising regularly lately. After a couple of days, I couldn't even walk 50 yards without feeling out of breath.
And any recent illnesses, like the flu or bad cold?
Yes, about 2 to 3 days before I started feeling out of breath, I had a flu-like illness, with the normal generalised muscle aches and fever. I rested for a day or two and then felt better until I started my routine, and that is when the breathlessness got worse, not better. It's hard for me to wrap my head around it. I'm still young, but I feel like sometimes I'm gasping for breath like a 90-year-old running a marathon.
I bet you are also feeling quite tired.
Yes, how did you know? I feel extremely tired at times, and also I have noticed heart palpitations and some discomfort in my chest, along with breathlessness. I'm not sure if that is related to the breathlessness, but...
Any changes in routine or lifestyle? You said you thought the breathlessness might be due to lack of exercise.
It has been a tough semester at uni, so I have not been exercising as much as I would like, but I still manage to go for a run 2 or 3 times a week.
Oh, okay. So you would say you are generally a fit person. And any experimentation with drugs?
No substance abuse. I know what you're thinking. Young person in uni must want to experiment, but nope, that's not me. So what does all this mean? You have heard my symptoms now, and you have my tests.
So your chest x-ray was normal, which is good, but I'm afraid there are some abnormalities in your ECG. This, along with the symptoms you described of fatigue, shortness of breath, pericardial pain, and palpitations, points to myocarditis. The flu-like illness you described is also compatible with this disease. I asked about substance abuse because one cause of myocarditis is cocaine use. So...
I see, and I get it. You have to ask. OK, so what does that mean exactly? Viral myocarditis? Is it something wrong with my lungs or my heart or...?
Myocarditis is an inflammation of the heart muscle, and the viral part refers to the fact that a virus is the cause. There are a number of viruses that can cause this problem, including Coxsackie B and A, echovirus, and varicella.
Isn't varicella chickenpox?
Yes, it is.
So is this serious?
Well, first we'll need to perform an echocardiography to confirm the diagnosis, and we'll also do some investigations to test for the cause of the myocarditis. Based on the fact that your chest x-ray was normal, the myocarditis is likely mild, so that is the good news. The maybe not so great news is that you will need to be on bed rest for a while. Most cases of myocarditis are benign and cardiac function returns to normal, but resting is an important part of treatment.
That will be a bit difficult, but I will have to see what arrangements I can make at uni to lighten my load for the next.
That is the end of Part A. Now look at Part B.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase.
Hello, Mr. Jakey. It is nice to meet you.
Hello, yes, it's great to meet you as well.
So, tell me, Mr. Jakey, you are here because an investigation showed microscopic hematuria.
Yes, I was in the process of applying for a new job about, I think 6 months ago, and I had to get a checkup for insurance purposes. That was when blood was found in a urine sample.
Okay, and also you followed up with your GP, is that correct?
Yes, that is correct. Since that initial analysis, my GP has run 2 additional tests that confirm what was previously found.
But you have not noticed any blood in your urine or any other urinary problems, right?
Yes, right. That is why I was quite shocked when I got the results from that insurance medical. I mean, I consider myself a generally healthy person. I mean, if you were to ask me, I'd say I was doing pretty good health-wise. No major medical issues or anything like that.
What about your relatives? Anyone had any problems with their kidneys? You know, renal disease?
Not that I'm aware of.
So, I have the results of some recent blood investigations that your GP recently had done. Most of the items are within normal ranges, such as your hemoglobin and platelets. Also, your glucose level looks good.
I feel a bit nervous coming here, actually. Was there anything out of the normal range?
A few things, actually. We took your blood pressure at the beginning of the visit, and it is quite high at 146 over 102. As for your investigations, the level of urea was quite high, and also creatine was out of the normal range. Also, your level of gamma-glutamyl transpeptidase is very high.
What is that last thing? I've no idea what it refers to.
Well, a high gamma-glutamyl transpeptidase level is compatible with liver disease related to a high alcohol intake. The recommended upper limit of alcohol consumption for men is 28 units per week.
I see. Well, I'm going to have to work on that. I often drink a few more units than that per week.
Yes, I would definitely recommend that. In fact, I think you need to completely abstain from alcohol for the time being.
So, does my drinking have anything to do with what's wrong with me? Or is something else going on?
Well, microscopic hematuria has many renal and neurological causes, such as prostatic disease or stones, but the renal impairment, which is indicated by the high urea and creatine levels, along with the hypertension, point to some form of chronic glomerulonephritis, which is an inflammation of the tiny filters of your kidneys. You can think about it like this. The tiny filters of your kidney work to remove excess fluid, electrolytes, and waste from your bloodstream and pass them into your urine.
How concerned should I be? I mean, is this serious or long term?
Well, about 20% of patients with this condition will go on to develop end-stage renal failure within 20 years of first developing it. So it is something that may affect you in the long run. Also, this condition, along with your declining liver function, is very concerning. We will need, I think, a liver ultrasound and probably also a biopsy to see the extent of the damage to your liver.
I see. So no more.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio.
Now look at question 25. You hear a conversation about a patient's upcoming discharge. Now read the question.
Hello, Mr. Simons. So you know what today is, correct?
Yes, today I'm getting out of here.
Yes, exactly. And I just wanted to go over your discharge plan one last time. So you already spoke with Dr. Sheldon about your medication. We are sending you home with enough medication for the next week. And we will also be sending a letter to your GP with information about your medication. Also, there is the topic of transport.
Yes, my daughter is going to be here at 2 to pick me up.
Okay. And is your daughter going to be able to stay with you for a bit to make sure you have everything you need, such as food and other essentials at home?
Yes, she has tomorrow off, so she can help me all set up. I'm going to have to see about transport for my follow-up appointment with my GP, but there is a bit of time to work that out. Maybe my son...
Question 26. You hear a nurse doing a pre-admission assessment. Now read the question.
So, Mr. Phelps, now that we have gone through your current health and medical history as well as your home situation, I want to go through a bit of advice about your admission to the hospital.
Yes, that sounds very helpful. I've never had surgery, so I'm a bit worried.
No need to be worried, but it is important to follow my advice. So, first of all, the day before surgery, we're going to run some tests. So you will need to make sure that you have those done. In addition, 48 hours before you come in for surgery, we will need to stop taking the blood thinners that you're on.
I see, and what should I bring to the hospital?
Well, since you'll only be staying for 2 days, you only need clothes to go home in and...
Question 27. You hear part of an information session for the public about when to go to the A&E. Now read the question.
Welcome everyone. I'm delighted that everyone could be here today to go over several topics related to your healthcare. The first topic we're going to cover is when to go to the A&E. So, an A&E department, which is also known as an emergency department or casualty, deals with genuine life-threatening emergencies such as loss of consciousness, chest pain, severe bleeding that cannot be stopped, and stroke. Other serious emergencies, including severe allergic reactions and severe burns and scalds. Less severe injuries can be treated in urgent care centres or minor care units. Most importantly, the A&E is not an alternative to a GP appointment. If you are experiencing changes in your health that you are concerned about, it is essential that you make an appointment with your GP, as he or she is best positioned to follow your medical history and make the necessary referrals should you need specialised care. Another reason that A&Es are often short-staffed, meaning that patients that are not going through potentially life-threatening situations are taking away precious resources from those patients that truly do need these resources. And finally,
Question 28. You hear part of a training for dentists about easing dental fear. Now read the question.
Many people feel nervous or afraid of visiting the dentist. But as dentists, there are a few simple things we can do to help our patients overcome their fear. First is to be open to having potential patients come and visit the surgery, meet the receptionist and you, the dentist, in order to get a feel for the environment. If possible, make time to talk with anxious patients about what their fears are. The next tip is to have your receptionist advise anxious or nervous patients to pick an appointment time early in the morning so they have less time to dwell on their feelings about the appointment. Speaking of this first appointment, it should be a checkup, not a treatment, as this will give the patient time to get comfortable with you and your staff. During this checkup, you may want to discuss with patients a sign to signal that they need a break and that they want you to stop. It should be something simple, like pointing your finger. This will help the patient feel more in control of the situation. So, some types of patients that may be anxious or fearful of the dentist are
Question 29. You hear part of a training for junior doctors. Now read the question.
So you have made it through your medical training and now you have been released into the world. Now what? How do you start to make your mark on the world? It may feel as though you will be stuck in the role of junior doctor forever and that there is nothing you can do about it. But this series of training sessions is focused on skills that you were not taught in your medical training, but that are definitely necessary if you want to be successful in your medical practice. So, the first session will deal with leading as a junior doctor within your organisation. Topics include how to successfully chair a meeting, how best to negotiate with seniors and executives, and how to use social media for the benefit of you and your colleagues. So chairing a meeting, which is challenging and a skill that few receive any formal training for, effective chairing is critical to ensure a successful meeting and require preparation and awareness of this role. You need to know about the scope of the meeting, such as how essential the meeting actually is, what the aims and desired objectives of the meeting are, and what is the clearest and most concise way to achieve those aims. Another consideration is who will attend the meeting. Next, once you are in the meeting, it is important to
Question 30. You hear part of a ward briefing on a mental health unit. Now read the question.
Hello. Well, everyone, so as you are all probably aware, we are at capacity with no beds currently available for incoming patients. So this means that patients experiencing a mental health emergency are waiting in the emergency department for long periods of time. What the hospital has decided to do at this time is to use vacated ward areas in other parts of the hospital to put mental health patients so that they are not waiting in the emergency department. While that is great news for patients, it will put a strain on nursing staff, so we will need to continue to care for our current patients as well as those being admitted to the vacated ward areas. If you are able to take on extra shifts, please let me know so that I can make the necessary changes. Also, a few nurses from other departments are being transferred to our ward and will be going through the required training. I appreciate your assistance and cooperation during this time as we...
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear part of an interview about problems that junior doctors face. You now have 90 seconds to read questions 31 to 36.
So, hello, Dr. Stallings. It is nice to have you here today to talk about a topic that has captured the attention of the nation, the plight of junior doctors in our national healthcare system.
Yes, it is a very serious problem that has the potential to have a negative long-term effect on healthcare in our country.
So tell me, what you see is the crux of the problem.
It is definitely a complex problem. So coming to just one cause is not possible. But what I would say is that morale among junior doctors in our country is at an all-time low, which explains why resignations are rising, but also, sadly, why suicide among doctors is such a huge problem.
Well, resigning is one thing, but suicide is another matter altogether. Why do you think this is such a problem among doctors?
It is mostly due to the pressures of our work. I mean, people who have trained to be doctors are incredibly committed and passionate about what they do. So there is a tendency to try work through the pressure until, of course, it becomes too much. Just a statistic that can help to illustrate the severity of the situation. Female doctors are reported to be 4 times more likely to die by suicide compared to females in the general population.
What do you think needs to be done to start to tackle this problem?
Well, the first thing is to acknowledge the problem. One colleague recently wrote an interesting post in a prominent journal, and her main point was that we need to stop the culture of shame that is part of the culture of our national healthcare system and come together to create safe spaces for staff to learn and reflect together. It is somewhat ironic that it is our life's work to take care of others, but we do not have structures in place to ensure the well-being of all staff.
So a few moments ago you mentioned resignations. What do you think would lead a doctor who, as you stated, starts off so full of enthusiasm for the profession to resign?
Well, in my experience, the number one reason is professional passivity. You come full of energy and enthusiasm, and you think you can change things for the better. But then you confront the system. You try to raise issues of concern and are met with walls. Eventually, being ignored leads to disengagement.
I see. I'd never thought of that. So, what do you think can be done to solve this particular problem?
Well, to remedy this, junior doctors must be encouraged and enabled to be involved in professional development opportunities, such as leadership and research. Many are not permitted to be involved in these activities as the focus is on the provision of services. While I understand there is a shortage of doctors, such as GPs, forcing junior doctors to only focus on service provision is short-sighted. Research by leading organisations has shown how important flexibility is in maintaining doctors' well-being. In addition, developing non-clinical skills is of utmost importance for the future of training and healthcare as a whole. Providing junior doctors with the opportunity to develop leadership and research skills could definitely improve trainee satisfaction and therefore improve retention and recruitment rates.
So is it all gloom and doom for junior doctors, or is there some hope?
No, of course there is some hope. In fact, things are on the cusp of improving. Junior doctors are coming together to advocate for quality improvement and for learning about the managerial side of the job so that beneficial changes can be made. For example, our focus group of junior doctors showed that some places of work are putting into place new ways of developing ideas, such as through regular meetings with the medical and managerial teams to highlight problems and work together to resolve them. There are also some efforts that, while well-intentioned, need to be reviewed to make sure that they are effective as they can be. For example, the mandatory e-learning modules need to be reviewed to look for ways that they can be made more flexible and for ways that doctors can have more of a role in shaping their own training. This would mean that junior doctors would engage more and stay in posts that are beneficial to their career, and it would also allow for other, more practical activities, such as discussing difficult cases, to be valued as learning activities.
What about mentoring schemes? Are they viewed favourably by junior doctors?
Oh yes, they certainly are. I was recently part of a mentoring scheme, and all the mentees and mentors found it very useful in their professional practice. In particular, mentees said it helped them to feel more engaged and that it was beneficial for their health.
Now look at Extract 2. Questions 37 to 42.
You hear a presentation about a new infectious disease. You now have 90 seconds to read questions 37 to 42.
So, we are all here today as part of a worldwide response to a new virus, a virus that belongs to the large family of viruses known as coronaviruses. Just to give us some background before getting into the details of the current outbreak, coronaviruses are generally zoonotic, meaning they are transmitted between animals and people. Rarely, animal coronaviruses can infect people and then spread between people, such as with SARS, MERS, and now the new virus, officially named SARS-CoV-2. So, the first coronavirus outbreak that I'm going to discuss is SARS, which was first reported in Asia in early 2003. SARS stands for Severe Acute Respiratory Syndrome. The illness then went on to spread to more than 24 countries in North America, South America, Europe, and Asia, before the SARS global outbreak was contained. There have been no reported cases of SARS since 2004. So, patients with SARS reported high fevers and other symptoms, including headache, an overall feeling of discomfort and body aches. Some people also experienced mild respiratory symptoms at the outset, and 10 to 20% of patients reported having diarrhea. After 2 to 7 days, some SARS patients went on to develop a dry cough, and most developed pneumonia. MERS stands for Middle East Respiratory Syndrome, and it is a viral respiratory illness first reported in Saudi Arabia in 2012 and has since spread to several other countries, including the United States. Most people infected with MERS develop severe respiratory illness, including fever, cough, and shortness of breath. The animal source of MERS is likely to be camels, and studies have shown that direct contact with camels is a risk factor for human infection with MERS. However, more research is needed to understand the interactions between humans and camels in order to get a more complete picture of how transmission takes place. Another important piece of information is that while there are ways to test a person for MERS, and there are treatments for the disease, there is currently no vaccine available to protect against MERS. Like MERS and SARS, the SARS-CoV-2 is a beta coronavirus. Early reports of the current virus linked the outbreak to a large seafood and live animal market in China, suggesting animal-to-person spread. Later, a growing number of patients reportedly had not had contact with animal markets, marking the shift to person-to-person spread. Person-to-person spread has been reported outside of China, including in the United States, Japan, and other countries. Most recently, other places have apparent community spread, meaning that some people have been infected who are not sure how or where they became infected. While both MERS and SARS are known to cause severe illness in people, there is still much unknown about the current virus. Symptoms of the SARS-CoV-2, or what many media outlets are calling COVID-19 virus, include fever, tiredness, dry cough and shortness of breath. Some patients also experience aches and pains, nasal congestion, runny nose, sore throat and diarrhea. It is currently believed that symptoms may appear in as few as 2 days or as long as 14 days after exposure. This is based on what has been seen previously as the incubation period of MERS. It is worth noting that while the risk of catching COVID-19, COVID-19, from a person with no symptoms is very low, many infected people experience only mild symptoms, particularly in the early stages of the disease. Currently, most people, about 80%, recover from the disease without needing special treatment, but around 1 in 6 infected become seriously ill and develop difficulty breathing. Older people and those with underlying medical problems like high blood pressure, heart problems or diabetes are more likely to develop serious illness. So far, about 2% of people with the disease have died. It is worth noting that this fatality rate is much lower than that of SARS, which was estimated at 14 to 15%, and then that of MERS, which has a fatality rate of approximately 35%. However, the situation with the new virus is still evolving, and numbers may change once more data is available. Also, currently it is believed that the new virus is much more infectious than either of the other coronaviruses that have been spread between humans, which is part of the reason there are currently so many new cases identified each day. As with MERS, there are currently no vaccine available. There is also no specific antiviral medicine to prevent or treat COVID-19. Possible vaccines and some specific drug treatments are under investigation and are being tested through clinical trials. The World Health Organization is coordinating efforts to develop vaccines and
That is the end of Part C. You now have 2 minutes to check your answers.